I'm Peggy Peck, MedPage Today, and this is In Focus at the American College of Cardiology in New Orleans. I'm speaking now with Dr. Marriell Jessup, who's a professor of medicine at the University of Pennsylvania and a board member of the American Heart Association. Dr. Jessup, big news here is results of the PARTNER trial, which was a comparison trial comparing surgery for aortic valve stenosis to a transaortic, a percutaneous approach to valve replacement. And turns out that it looks like, at least at a year, that there's really no difference. These procedures are sort of equal, except a higher stroke rate with the percutaneous approach. So I've heard this referred to it as we're seeing history in the making, that this is going to change clinical practice. I'd like to get a little bit of an assessment from you.
Well, thank you, Peggy. I agree that this is a very exciting time. Anytime we have a new surgical approach for a very common problem, we all pay attention. And the problem of the elderly patient with multiple comorbidities that has critical aortic stenosis is one that many cardiologists have to face on a very frequent basis. These are fragile people, no matter what we do to them. Even cardiac catheterization is hard on them. And to face these patients with an aortic valve replacement, the typical surgery is really tough. So the TAVR is a new possibility, and we did learn something from this. I think it's important to note that this is a population that has some particular characteristics. One is they did not allow concomitant bypass surgery. So the patients that were chosen did not need coronary surgery in addition to the aortic valve. So that's one thing we know. But what we do know is it was an elderly patient population. The mean age was 85 years of age. They had critical aortic stenosis, and this does represent the group. What also came out of this study, in addition that there's now a choice between surgery and this TAVR procedure, is that we're getting good at this. That the traditional aortic valve surgery, the 30-day mortality was decreased. It was predicted to be 11%, and it was down to 6.5%. And the 30-day mortality with the TAVR procedure was the lowest that has yet been reported in this procedure, and it was down to 3.4% at 30 days. So we're getting better at it, and we understand what the risks and benefits are of the two procedures.
Now, what happens now, even with, when I say now, I mean when we've had the traditional surgery for this procedure, is that it's my understanding that many people who developed aortic stenosis are actually not referred for surgery, and they just never make it to the surgeon's door. They're managed with medical therapy, often because they are so fragile. Maybe they're not even interested in surgery. So this is a new option, and that could change that conversation that the cardiologist has. When we start with the cardiologist, that they have in laying out the options for the patients. I heard it estimated today that this will start, they would predict, now the device is not approved yet, but if it were approved, we could assume that it would start with thousands of patients, move rapidly to tens of thousands of patients, and potentially affect hundreds of thousands of patients. I'm going to ask you, hyperbole, or does that seem about accurate?
I think that is accurate. I think whether people, once they understand that this procedure does go on in an operating room, so it still is surgery. It's not having your chest necessarily opened up. There's a smaller insertion, especially the transfemoral approach. The transapical, obviously, they still do have to have a heart surgery. So when patients, when they come in asking for this, because my hospital was one of the sites where it was going on, I think they have sometimes a false picture of the extent of the procedure. Nevertheless, it is going to increase the options, and there are many conversations that will now have to go on with the elderly, fragile patient with critical aortic stenosis, whether they want to accept the natural history of this disease and not do anything, whether they'd like to risk aortic valve surgery, or now whether they want to risk the TAVR procedure, and understanding the risks and benefits. We have to say with caution that the stroke risk was higher with TAVR, and many times people, especially 85-year-olds, fear stroke worse than death.
Mm-hmm. Another thing that's, that I found interesting in speaking to some of the investigators is the way this decision, the way the conversation went, so to speak, and it was very reminiscent to me of the, from the Syntax trial, which the Syntax trial compared CABG to coronary artery bypass graft to stenting for complicated coronary artery disease. And one of the issues in that study was that the decision which way the patient would go was a team approach. They called it the heart team, the surgeon and the interventional cardiologist, the medical cardiologist as well. And I've heard that this is Mike Mack, one of the investigators in this trial, in the partner trial, told me that that partner is going to take the Syntax heart team and kick it up to a whole new level. And because this is the way it will have to be done, it will have to be this team approach. And I always think that sounds great. But you're in the real world at the University of Pennsylvania, and I'm wondering how much teamwork is going. Are people interested in forming that heart team and getting it out on the field again?
This team had to be already formed to do this procedure. So it is real-time, hour by hour, day by day conversations with the nurses, the surgeon, and the interventional cardiologist. And it's remarkable. So not only did they have to build a whole new laboratory or operating room,
a hybrid room,
this,
they call it.
A hybrid room, exactly. But there's a whole team, that multidisciplinary team that works together. And the other thing that we have to be prepared for is now the ongoing longitudinal care of these patients. These are patients, let's face it, that oftentimes died. They died without surgery, or they died of complications of surgery. And the information we got today is that the mortality rate of the procedure, either aortic valve replacement or TAVR, is going down. And we are going to have to find new doctors that are willing to take care of these patients and follow them until, you know, whatever happens.
So I just want to get so your take on this. So this is a is this historical? Is this a major win for an interventional approach to structural heart disease?
I think our caveat still has to be, let's see what happens after a year. So what's going to happen to the stroke rate? What's going to happen to the longevity of these valves? It is the advantage or the lack of advantage at 1 year, is that going to be maintained? And then in the end, because we do have to talk about utilization of our overall resources, we're going to have to look at cost benefit. You know, is this the right thing to be doing in this very elderly population? But anytime you break a norm, and our norm has been aortic valve surgery with a traditional approach versus no surgery, we now have another option, and that's always historic.
So history here in New Orleans at the American College of Cardiology. For InFocus, I'm Peggy Peck, MedPage Today.
Okay.
Thank you.